Okay, let's go and get started. My name is Yvette Subramanian. I'm the Publications and Events Coordinator here at CITRIS, and I'd like to welcome you to today's research exchange by Professor Deryk von Brunt, using information technology to build healthier communities. A few announcements before we start. First, of course, thank you to Infineon Technologies for sponsoring the lunches. You guys are all enjoying. Welcome to the webcast viewers and people at the other CITRIS campuses. I always like to say hi to them. And finally, most importantly, this is the last research exchange of the spring semester. So we're ending on a nice high note, but don't come back next week looking for lunch. We don't have any. To wait until September 3rd for that, and we'll have this agenda out, or the schedule out sometime in the summer. So I'd like to introduce Professor Deryk von Brunt. He's an associate clinical professor here at UC Berkeley, the School of Public Health. He's also the chairman of the Healthy Communities Foundation, and he should have a fascinating talk.
Thank you. Well, good afternoon, everyone. It's fun to be here, and I'm looking forward to some lively discussion. I'm going to talk about community health information systems this afternoon, and by that what I mean is how information technology can be used to improve some of the tracking and reporting of health measures at a community level, and just as, if not maybe more importantly, promote best practice sharing amongst different communities around everything from traditional health interventions, childhood obesity, smoking cessation, etc., to other factors that influence health, such as environmental sustainability, the built environment, public safety, etc. So that's kind of the world that we're going to move into. Now, I understand that many people here today don't have a healthcare background, so I thought I'd spend a couple of minutes and just level set with some of the challenges that we face here in the United States with respect to health status and the delivery of healthcare services. Then go into where we seem to be, as a country, deploying most of our energy in the application of information technology in healthcare. And then I'm going to identify a problem or a challenge that I think collectively we face, which is most of the current development and evaluation are going into areas that are very important, but I'm not sure they're terribly well balanced, in that there are areas that we're not investing in very much that may ultimately have a greater impact on health status. And so with that as sort of a transition, I'll go into sort of a case study of a grant that we started in 2002 to look at the use of information technology to promote community health, and what was our process during that grant. And the result is that we've put together a web-based prototype, which I'll demonstrate this afternoon, and I look forward to your feedback on that, and then we'll go into some discussion. So I have roughly half an hour of a presentation, and I've left roughly half an hour for us to talk. So by way of background, roughly 40% of the population here in the United States have a chronic condition. Chronic condition means a condition which typically does not go away during your life. It has to be generally managed on an ongoing basis. Usually it's progressive, which means you can't just have, if someone has diabetes or asthma, COPD, various hypertension, high blood pressure, these, you can't just put someone on a medication and say, you're fine, just keep taking your meds. The disease can progress, and therefore you have to keep track of them, check back in on a regular basis. It's a fairly informational intensive process. So there's a lot of room for improvement there, which we'll talk about in a little bit. Some of the contributing factors to the very high levels of chronic disease rates that we have in the United States have to do with an aging population, which is a good thing. So as we get older, we have more health complications. But we also have a variety of lifestyle issues, obesity and inactivity, which are on the rise, increasing in the last 15, 20 years from roughly 20% of the population that was considered obese to now 34% of the population, it's adult population. So this is all talking about health status and some of the trends within that are contributing to some of the poor health that we have in the United States. Now, separate from that is the quality of care that we deliver once you walk into the walls of our healthcare delivery systems, hospitals, physician groups, etc. Now, the Institute of Medicine put together a landmark report back in '99 and basically estimated, I should say, that somewhere between 44 and 98,000 deaths occur annually here in the United States that are preventable and are based on medical error. So and that, by the way, just to translate that, that's like 2 747 jets going down every day, all lost. So in the healthcare community, that gave people a great deal of pause, and not only because of that, but that certainly contributed to the fact that a great deal of energy has gone into developing information systems that can improve clinical decision making and reduce medical errors. And I'm going to talk a little bit about that, but that's not the main point of today's presentation at all. We also have widespread variation of clinical practice, meaning we know what the evidence base is, how you treat a certain condition, but that doesn't mean that's actually what happens when people walk in to see their physician. That has to do with the amount of time physicians have, information that they have access to or don't. It also has to do with reimbursement. If you're not being reimbursed to keep someone healthy, then you're going to take care of an immediate problem and very nicely say, you know, goodbye, I've got the next patient. No ill will towards any physicians that by and large are very good and try very hard every day to help people. But if the system doesn't provide the right information and the right incentives, then people will focus on what the immediate task is at hand. The last thing I want to point out by way of background here is that we spend about double on health care per capita in the United States than most countries do in Europe. And yet our health status is about the same. In fact, depending on the measures you look at, it's actually a little bit worse. So the value for our health care expenditures is not very high. And just to quantify this a little bit, we're currently a little above 15% of gross domestic product being spent in the healthcare sector. Now, these high costs, which are double-digit increases, they impact all of us fundamentally in two ways. One is, as we individually pay for health insurance or our deductibles, our rates have been going up, in case you haven't noticed. At the same time, and a lot of people are uninsured because they can't afford health insurance. So it's a vicious cycle. But if you look at the ultimate payers for healthcare delivery in the United States, typically employers and government, they also are footing a higher and higher bill. And that's making U.S. companies less competitive in the world market. So just to give you one example, General Motors about a year and a half, 2 years ago, mentioned that before they buy one scrap of material or hire 1 minute of labor to build any car, I'm talking about design, production, anything, before any of that money is spent, they have $1,600 of sunk cost into each car based on health care and other benefits that they're obligated to pay. And they're saying it's impacting their competitiveness globally. And that, of course, relates to jobs, and that also then relates to health. So getting a handle on improving health status and keeping a curb on expenditures is paramount. And within that, the only thing I want to add is people with chronic conditions, that 40% of the population, that's where 70 cents of every dollar goes, is managing people with chronic conditions. So that really is kind of, you know, the big gorilla in the room. And so you'll hear me talk about chronic conditions and disease management, managing people with chronic conditions. You'll hear me talk about that a fair amount during this talk. I don't mean to exclude all the other sort of 30% of the expenditures, but it helps us focus because it's one topic that has a very great burden in our country. All I want to say here is that the demographics, the lifestyle issues that contribute to all these chronic conditions, they're not going away. The sedentary lifestyles, obesity, smoking is actually very slightly coming down. But by and large, these are trends that aren't going away. So the predictions around where our costs are going just continue to go up. And on the second major bullet here, our healthcare delivery system is optimized to handle acute care, episodic care, meaning you have a problem, a broken arm, a heart attack, a stroke, you come in, you get care. Our quality, by and large, is very good, putting aside those medical errors we talked about earlier. And so that's kind of really goes back to the roots of how our whole healthcare system and reimbursement method was developed. But when you have a chronic condition, our track record of helping people manage their chronic conditions is actually quite poor and very different. Okay, so when we look at information technology as it's being applied to improve health here in the United States and healthcare delivery, there are a variety of ways you can categorize. I tend to use these 7, and different people use different categories. The first 5, administrative information systems tracking who's paying who for what care, clinical information systems supporting clinical decision making. The first 5 listed are all where the vast majority of expenditures go today in the development, deployment, and evaluation of information technology to improve health in the United States. And I, for one, I'm not taking anything away from that. Those are all very important areas. But the last two, consumer health information systems and community health information systems, may hold promise, and I'll give you some evidence for this in a moment, for tremendous impact on health status here in the United States, tremendous opportunity to harness some of our escalating costs. And I'm going to talk more about those, in particular, the community health systems. Just to go back to the first five, some of the areas that get a lot of attention today and a lot of activity are electronic medical records. President Bush, a few years ago, called for an electronic health record for all Americans within the next decade. We had that Institute of Medicine report, which said, wow, we need to have much better availability of information in the walls of healthcare delivery, so when you go from provider to provider or insurer to insurer, that the information about you is followed around. And so there are a variety of different kinds of information systems that are being deployed. Let me just ground this with, say, one example. Computerized physician order entry, CPOE systems. What these are, let's say you're a physician and you've just met with a patient, you want to order a lab test or order a prescription. Instead of a handwritten note, you go to one of these CPOE systems, and now you have drop-down menus. So you pick the drug, you have, what dosages are traditionally available, you pick the dosage. So you're doing pick lists. And then let's say you're about to recommend a drug to a patient for which they already have other drugs they're taking, and there may be a contraindication, danger associated with giving them these two different drugs. But the physician about to write the prescription didn't know that. These physician order entry systems will come back with an alert saying, are you sure you want to order this drug? The physician can trump it, but the idea is they have information brought to them to make the best decision possible, and all of the handwriting errors and these kinds of things are greatly minimized. So there's an example of a concrete technology that's being implemented. I don't know, I think deployment now, penetration in the United States is, call it roughly 20% of hospitals in the United States have CPOE systems. And just to give you one statistic, this is a government accounting office report, did an evaluation of a 350-bed community hospital, and in the first year of implementing a CPOE system, they reduced medical errors by 1,200. 1,200 medication-related medical errors went away. So that's great. And I think any of us that are going to get medical care want this kind of development in these systems to go into place. But I'm now about to make a pretty serious departure, because they can only go so far, and here's generally why. If you look at the determinants of health, and that is, Health and Human Service reports, plural, that basically say, of what we know contributes to health status, and we don't pretend to know everything that contributes to health status, the estimates are that medical care, i.e. access to and quality of, is about 10% of the equation. And then you've got your genetic makeup. But over 50% is related to lifestyle and the environment. And those systems I described earlier, where over 90%, if not over 99% of the deployment of resources in terms of the implementation of information technology in healthcare, are not focused in the environment and lifestyle, at least not until quite recently. Just recently, we've had an interesting pickup on personal health records. We've read about Google and Microsoft, and we'll talk a little bit about that in a moment. But by and large, up until now, this has really not been an area of great research. Now, again, I'm going to create some arbitrary categories here just to quickly kind of give you a summary of, at least in my opinion, where we are today. So I tend to look at 4 different generations. This classification came from someone here at Berkeley, Michael McDonald, who's over at Georgetown now. And the first generation was in the mid-90s. And in the very beginning of the Internet, we basically had what are called information and referral systems. These helped people just move from one point to another in the healthcare system, i.e. help find a doctor, maybe someone that speaks your language, find the address, that kind of stuff. The second generation is what I'll call the big library in the sky. That's the WebMD libraries at the time, drcoop.com, Adam, HealthWise, etc. And we're going to talk a little bit more about those. And that's the reference information phase. And that was right around the year 2000, plus or minus a couple. We're now in the third generation. These are personalized health information systems. The information that you get is specific or related to you and your condition. I'm going to explain that a little bit more in a moment. The fourth generation is, I think, something we haven't really embarked on. And that's actually what I'm mostly going to talk about this afternoon. And that is individual decision making is nested, in fact, within a community. Let's just take a quick example. Whether or not you smoke is related to things like where you go to school, who you spend time with, what your values are, what your parents told you about this, etc., etc. It's a broader issue than just purely an individual decision. And so we're going to talk about the importance of that and what we can do about that, how information technology can help. So just a little bit more about consumer health information systems, and then I'm going to shift over to these community health systems. Now, this is sort of on the lighter side. The joke reads, well, www.whatswrongwithme.com says it's just a virus, but I came to you for a second opinion. Well, this is a joke, but in a way it's not a joke, because if any of you are physicians or spend time with physicians, you'll know that the practice of medicine is changing fairly dramatically. And one of the differences is that I'll call it, a bit casually, in the old style 20, 30 years ago, it was more of a command and control. Physician, 100% authority, you walk in, you get advice, here's what you're going to do, boom, 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 out the door. Today, it's more of a consultative role. Obviously, that's a continuum, and different people are in different places on that continuum. But physicians are beginning to see themselves more and more as helping people understand what their choices are. Treatment choices, choices of different physicians, procedures, etc. And then people have a bigger say. So there's a little bit of a locus of control change. And some of the evidence of this, now on the second generation, the library in the sky, and I don't want to spend too much time here, but we basically have over 2/3 of Americans online. For children, it's over 90%. Of those people that have gone online, over 90% have looked for health-related information. Okay, so it is typically the first, second, or third most trafficked topic on the internet, depending on which statistic you're looking at. And then if you look at, well, what impact has that had, you'll see that people talk about how the health information that they've seen has impacted decisions, it's impacted physicians they've selected, they've gone for second opinions. A great number of people said they could find more information online than any other source they could get a hand on. So there's been a huge consumption of this health-related information. Okay? But in terms of evaluation of impact on health status, we can come back to this if someone wants to discuss that, but marginal impact. There are a few studies, but after all, information does not trigger full behavior change. So I for one, wouldn't expect great health impact. Now, as we move to the third generation, which is the generation we're more or less in now, these are personalized health information systems. And because they're personalized, by definition, you need to know something about the individual. So I'll use the term personal health record. It means someplace, somewhere, there's data about you that is now being keyed or referenced to customize communication or content or some kind of application. Now, it could be a personal health record under your control. It could be a personal health record provided to you from a health plan or an employer or a provider. And again, if someone wants to come back and talk about this in our discussion, I'm happy to. But the point I want to make is that these systems are being used quite broadly. They are beginning to, we can now start emailing our physicians. It's not everywhere. It's not highly prevalent, but the penetration is growing rapidly. I'll give you one example to ground just how great a health impact these systems can have. Let's say you're managing a chronic condition. I'm going to describe a program that took place a few years ago. So these were people with asthma, fairly moderate to severe levels of asthma. If asthma is well managed, by and large, you can have next to zero hospitalizations. If it's not particularly well managed, you can have quite a number. So this is what's called a pre-post design. In the first year, this group of roughly 30 asthmatics had 81 emergency room visits. This is standard of high quality, standard of care. Okay? These are ill people. Then they received what are called biometric devices. It would happen to be, in this case, a digital spirometer that you breathe into and helps you measure lung functionality, what's called FEV1s. And that information was then basically put up on the internet and then reviewed by a professional. So these people approximately, depend on the patient, once a day would breathe into this, and you would now have a web-based system where you could see how their lung functionality is doing. This same group, once that biometric feedback intervention was put into place, had a grand total of 1 emergency room visit in the second year. 81 to 1. Now that means much better health outcomes. Think about the individual. I don't want to go into the emergency room and have that agony. It's a very scary experience, as I understand it. And in terms of cost control, it's very large. Why does that work so well? It works because the patient is part of the program. There was no magic. You upload personal biometrics as one example. People pick up the phone and call you and say, hey, your lung functionality is trailing. Why don't you come on in the next day or two? You can often see with asthma 3 to 7 days in advance. You can see trailing abnormalities in lung capacity before there's a triggered event. Not always, but often. So that's the kind of thing that these personalized information systems can do. And where they're moving to is much more integrated into healthcare delivery so that your physician ultimately will see this data, not just a nurse who's part of a disease management program somewhere. It'll be sort of an integrated delivery of care system. And again, a whole topic we can come back and talk about. Just to finish the point, it's actually getting really exciting because all of this is going wireless. So today, down in Palo Alto Medical Foundation, Paul Tang and his group are managing people with diabetes, and they use what's called a blood glucose meter to measure their blood sugars, and they are BlackBerry, basically using Bluetooth, scoops the data off of the blood glucose meter, puts the data up online in an electronic medical record, and the physician team and the patient have access to the data. So it's exactly analogous to that asthma study, except for it's around diabetes and it's wireless. And frankly, in a couple of years, it'll be wearables. You'll buy a shirt. The shirt will help you measure all kinds. Today, down in Los Angeles, you can buy shirts that measure temperature, heart rate, and a number of other things. We've already got pedometers you can drop on your feet for STEP programs. So all of this biophysiological data will basically be grabbed. Your weight, blood glucose, temperature, how much you've exercised, whether or not you've taken your medications, and all of this will be put into your records with evidence-based guidelines triggering alerts back to the care team and to yourself. So if that's an area, this is all the third generation, we're sort of in the middle of it. Now, that's not going to solve the total problem either. And that's now the next step. So the thing that, that we've looked at now for a few years is that the examples that I gave of people with asthma and diabetes, well, they already had asthma and diabetes. They already had, in some cases, they've had the lifestyles or the environment that triggered these kinds of conditions, or some of the preconditions that led to the severity of their condition. So how do we go upstream and use information technology to start improving lifestyle and engaging people at an earlier stage and affecting the physical environment in which we live? So these are some of the areas that started making us think years ago, we need to go past this personal health decision making, which is already a great improvement, and move a little further upstream. So back in 2002, I'm now going to shift from general market background. I'm going to talk specifically about a project that I and several colleagues have been involved in. And we got a grant, and the question that we basically asked is, how could information technology be used to help communities better track community health indicators and promote best practice sharing so that we could have more efficient interventions and create healthier environments? And that was a pretty big, kind of a lofty question. So we did a lot of things. We did literature researches. We did lots of interviews. We talked to county-level directors of health and human services, and we spoke to people in hospital councils and various health coalitions and advocacy groups, and on and on and on. And I'll sort of spare you all the detail. But as we kind of was doing our research, one of the things that we came across is a question that kept coming up is, how do communities change? Because if what you want to do is empower a community, the stakeholders in a community, to build a healthier environment, you need to understand how change occurs. You can't just put up information. It's kind of like those consumer health information systems. You can't just put up content and expect great changes to occur. It's got to become more personalized to the person. Well, for a community, same thing. How do we help stakeholders really get the information they need and communicate together to better coordinate activities and make change? So we had a number of questions and a number of findings. One of the findings that we had was that most of the information related to health and quality of life and environmental sustainability, it was all broken into silos. They were all department-based databases. Different departments weren't communicating very much. A lot of information was being reported on paper. You had to really hunt to find the data. If you found the data, it was a number in a table somewhere. It wasn't easily digestible. So these are some of the problems that we ran into. So one of the things that we did And I'm just making you aware of the process we went into. I don't plan to go into this in great detail. Is we asked ourselves, well, how does change occur? So a fair amount of research went into looking at change theories, both of how individuals make change as well as how communities make change, and everything from social learning theory and health belief models to social conflict and Freirean models. And we looked at all of these models trying to understand, okay, there are all of these different theories about how change occurs, and we simplified greatly. And these were sort of the common elements. I love being able to take several months of research and boil it down to 6 bullets for you. That doesn't mean they're correct, but they helped us digest what we had been understanding, because again, we want to build technology to make change, so we've got to have some sense of what we're trying to do. So the first is there has to be an awareness in the community of an issue, and then some sense of an assessment or severity. Does this matter? Is it important? Will it affect me or people I care about, for example? And then there's some sort of a communication phase that seems to occur, and then there's something magical called decision support. But even after you decide you want to do something, then you need to operationalize that. We all know, for example, in smoking cessation programs, people often want to quit. They're not successful most of the time. Operationalizing the decision is often the hardest part. And then, of course, you need some kind of tracking or records. So this was kind of our mantra of, okay, if we're going to build something, it's got to help communities do this. So again, I won't take you through all the weeds, but we then said, okay, what could we build that would support awareness and decision support and health assessment? And we came up with all kinds of ideas. Okay, so sort of that was a put it all up on the wall, break it into categories, and then we started prioritizing. And once again, we sort of burned it down. And this became our criteria for how we could help communities. So we said, first of all, we need to find a lot of the quality of life indicators, health, environmental sustainability, public safety, transportation, that impact health status. And we need to find a way to visually represent this data and get it into a place so people can see what's going on. So that was sort of one set of criteria that we came up with. The other is we need to find a way to help communities learn from each other, because one of the things that we found somewhat shocking is that foundations, government agencies, and all kinds of NGOs, etc., continually implement various programs, and they're often creating new programs and ideas without knowledge of what other people have tried that may have worked or failed. I was talking to the head of the California Endowment here in California, one of the biggest foundations in the state, and he basically said he knew that probably 50% of the dollars of programs that he funded, 50%, went into programs that would be dead in 3 years. He knew that. He just didn't know which 50%. So the point is, how can we facilitate best practice sharing? And then the idea is we need to keep this very simple, because communities, and what's a community? A city, a county, a region? Are we talking about a mayor's office, board of supervisors, principal of a school, public health researcher, large employer? The answer is yes. Yes, we're talking about all of these people, including us, the general public, that are part of this community. So how do we make it? These groups don't have a lot of money. So how do we do all of this in a way that won't cost very much for them to leverage all of this? Okay, so this is our criteria. We formed a nonprofit foundation. It's called the Healthy Communities Foundation. It's a 501c3. And the idea is that if we're going to build an asset, let's put it in a foundation so that it can get legs later and actually become widespread. And then finally, we designed a system. So all of that was to say, here's what we decided to build. We decided to build a web-based system that was something like a template, that I think of it sort of casually as any city could sort of download and just turn it on. That's the vision. That's not the case today. That's the vision. When you turn it on, what do you get? Well, you basically get two things. One is a core set of content and applications, but you also get a publishing environment that collects data. Let me explain each briefly. The first is that we've identified over 100 health and quality of life indicators that we can represent for any city, county level throughout the United States. So that's an example of core content. We have a database of best practices. Who's done what that worked or didn't work, because you can learn equally from both, in communities. Health-related promising practices, environmental promising practices, public safety, etc. And then we identified local resource databases, so who's actually doing work in the local community in different areas. And then we have a whole bunch of other features that basically make people aware of what's going on and facilitate communication. I won't go through all of the features right now. So this is what we set out to design. Now all of this template, you turn it on, boom, it's now there for a community, let's say Berkeley. So let's say here in Berkeley we would have such a site. Well, there are a lot of people here in Berkeley, and there are a lot of people here in this room that could improve what's in that website, that know about other promising practices, that have other indicators, that have discussion groups that they want to start. So this system is also a publishing system that invites the stakeholders in the community to enrich the system with their own knowledge. So it is both a push and a pull system. Okay? So we then went to 3 different groups: a large city, San Francisco, a small rural community up in the state of Washington, Whatcom County, and Marin County. And we basically formed relationships deliberately with 3 very different kinds of entities: a hospital council, a director of health and human services, and a coalition. So these folks are all funded differently. They have slightly different missions. We wanted to learn in implementing and piloting our system. And so with that said, let me now show you what we put together. So this is the San Francisco site. We're live, so this is what's there right now. It's not password protected, so you're welcome to go and take a look. And in San Francisco, they wanted to call it Health Matters in San Francisco. So this is their name. It's their URL. Remember, it's a template, but it has local ownership, if you will. And there are a variety of things here, roughly 20 features. I'm just going to point out 3 or 4. So one is that you see right up here in the middle towards the top these color-coded gauges. So these are the indicators I referred to, and there are over 100. In fact, in San Francisco, there are 153. And I'm going to show you a list of those in a moment. If we put all 153 on this home page, that's all you would see. And there are a lot of other things to do on this page. So we decided, it's called, in the sort of the internet development parlance, it's called eye candy, and you just sort of put it in a place where eyes go, and then you invite people to take a look and learn more and dive in. And so the kinds of indicators here, colorectal cancer rates, heart disease, hepatitis rates, etc. And these are randomly selected, these 6, out of the 153, and they're just painted. Every time you come to the site, you'll see a variation in which ones are pulled up. Actually, the local community can make some sticky if they want to, but by and large, it's random. And I'm going to go into these first to give you a sense, because this is, if we go back to our change model, this is the awareness part and the severity part. What's going on, what's working and not working. And so right up here is sort of the taxonomy. We actually have 9 areas of our taxonomy. San Francisco implemented 7. Health, economy, education, natural environment, public safety, social environment, and transportation. And obviously, we won't go through all of these, but just to give you a sense of sort of scale and breadth, you have children's health, chronic diseases, communicable diseases. I'm going to explain the coding, the green, yellow, red in a moment. Infant health, exercise rates, men's health, women's health, seniors' health, teen health, economic vitality of the community, affordability of housing, education rates, air quality, land use, toxins, social environment, transportation. Okay? So you've got a lot of information in one place, and it tells you green, yellow, or red. And the idea is intuitively, green's pretty good, yellow's medium, and red's not so good. So let's take a look at an example. Let's dive into one of these. So here under communicable diseases, we'll go take a look at tuberculosis. Now, tuberculosis in San Francisco is in the red. San Francisco is a progressive city. It's got a great public health department. Why is tuberculosis in the red? So we take a look. Maybe we're in the public health department, in which case you probably know that it's not a good value, but this would still be rather informative, as you'll see. Or maybe you're just someone who is a concerned citizen. So when you look at one of these indicators, let's just take a look at the anatomy of an indicator. On the upper left is your gauge, and you can see what the thresholds are for moving from green, yellow, or red. The basic theory is this. If there's expert national consensus about what are good and bad values, we use those. But that's usually not the case for these indicators. Usually what we have to do is go back to the source data, look at a distribution of readings. If you're in the better 50th percentile, and your city reading is in that better 50th percentile, it will give you a green. If you're in the bottom 25%, you're in the red, and if you're in the middle, you're in the yellow. So the threshold for being in the red for tuberculosis incidence is anything over 8 cases per 100,000. San Francisco has 17.7. So now we know why we're in the red. We can see that the data was updated in 2007. We can see for what area. And then we basically have a description of what is tuberculosis, Why is it important, etc. I won't go through all of that, but let's slide down a little, because then you see source data. And you'll also see, by the way, if there are any caveats on the data. Anyone working with data knows that there are caveats associated with virtually any population database. So we do our best to make sure and put that right up front. Here, basically, the data that we're being measured against is for a limited number of counties in California, not all counties. But if you scroll down a little bit, look at the kind of immediate breakdown we can see. So suddenly, TB rates, we can see from a racial standpoint, is predominantly in Asian Pacific Islanders. 3 times the rates of blacks and whatever, 12 times the rates of whites. So that would be of an immediate interest, even if you're not in a public health role. You could be city council. You could be running a rec center in Chinatown. Suddenly it's like, okay, why is this the case? And then if you look down a little further, you can see neighborhood breakdown, and you see, sure enough, and this makes sense now, that the Tenderloin, South of Market, and Chinatown are sort of high areas. So let's say you're in San Francisco and you're supposed to create a screening clinic for tuberculosis. Do you have a little bit of a better idea of where to put the clinic? It is fed to you very rapidly, and the whole right-hand side of this page is what's called contextual links. Different people look at data. In this case, we're just on tuberculosis. We could be looking at sustainable buildings. We could be looking at all kinds of different topics. Over on the right-hand side are contextually linked resources. So who is working on tuberculosis in San Francisco? So you can actually click on these, and immediately you see, oh, San Francisco has resources. San Francisco's resources website's loading very slowly. But you would see here that San Francisco offers free screening programs, and you can go right to who you would contact to maybe have them come to your school or some other program, what languages they speak, etc. So immediately you went from, is there a problem? Where is the problem? How severe is it? Who's working on it locally? How do I contact them? All right there. 2 minutes. The idea is to do that across thousands of topics. The other thing you could do, depending on your level of interest and responsibility, is, I'm just scrolling down the right-hand side here. You see related news and other indicators, is who's implemented different programs around the nation. So we can click on these, and now we see different groups that have implemented community programs related to tuberculosis management. This particular one happens to be in New York. And we rank all of these, we call them promising practices. Okay? They can be anything from a story to what we call an effective practice, which means there were some statistics around either how many people signed up or some kind of outcome measure. But then we reserve as an evidence-based practice the highest rating, which means that there was a proper methodology with confidence levels and good reporting. So you can immediately, refine your search, if you will, to those kinds of levels. But you can learn from all of them. And this particular group basically had a goal of reducing rates of tuberculosis and improving screening. And they engaged over 3,300 foreign-born people in their local community and had an 81% completion treatment rate. Okay, let's say you're in San Francisco and you're really interested in tuberculosis. Here's who you contact to learn about the successes and failures that program had. And you can go look up 5 or 10 others, and now you can base your work standing on the shoulders of others. Because I've done the lit searches, and folks, this stuff doesn't pop up on a Google search. So it's hard to find this. So what we're trying to do is collect all of this, make it contextually linked, so that people can basically float and find what they're interested in. So going back to the home page here, and I'll sort of wrap up on the demo. The idea is to, sorry, this is just loading a bit slowly. So the idea is, one, through the provision of indicators, help people, I'm following this change process, become aware of different health, environmental, public safety kinds of issues. What are some of those issues and the severity of those issues in your community, local to you? What are best practice sharing and communication tools to talk with others in the community? We haven't gone into that, but there are discussion groups and those kinds of things. And then basically help track over time how a community is progressing. So this is a version 1. We already have a long list of other things that we want to build. But I think I'll stop here on the demo, which we can come back to in a moment, because I'm just going to conclude some thoughts and then we can go to some discussion. So, so how are we going to evaluate this? Well, there are two kinds of evaluation. There's sort of process measures and outcome measures. And in the short term, we'll be pretty much constrained to process measures. So who's coming to the website in terms of, when are they coming? What resources are they looking at? Are they going to the promising practices? Are they going to the indicators? Are they going to the local resources? We're going to have surveys on the site. We will do off-site surveys to ask people if it impacted interventions that were developed or improved efficiencies and decisions. And so there are a variety of process measures. Ultimately, over time, the outcomes will be in the indicators themselves and how they progress. That ultimately will be the measure that we will all have. So some of the benefits we're trying to foster is really creating transparency and accountability at a community level around anything having to do with quality of life. Support the best practice sharing. There's basically no way a community can build and put all this together and maintain it. So we want to make sure that we're doing this in such a way that we can make it available on a widespread basis very inexpensively. And it helps different organizations, we found out, meet different regulatory requirements less expensively than they already were. In San Francisco, for example, they spent a certain amount of money creating a paper-based report every 3 years on sort of quality of life factors in San Francisco. This is the Hospital Council. For less money, they now can have this reporting double the indicators, constantly updated, tied to best practices, et cetera, et cetera. So it's that kind of benefit that we're trying to create. And as I mentioned, we're trying to collect knowledge from the community, not just push this information down. Some of the challenges that we have, all that indicator updating and content updating, it's a lot of work. So it's not for the faint of heart. Rating these promising practices is tricky. A lot of times we read these practices, they sound wonderful, but the methodologies don't sing across as really being all that rigorous, so we end up kind of downgrading them a little bit, which is hard for us to do, but we err on the side of being conservative. We've had a community want to delete a bunch of indicators because they didn't look good. So think of this as a tool set, and now a buyer, let's call it board of supervisors, wants to implement this for their community, but they say, geez, we're not doing too well in the environment, so let's delete that section. Technically, you can do that no problem, but do we want to let them do that? So no, exactly. So that's exactly so, and we're not letting them do that, but we are finding ourselves in discussions like, okay, maybe we'll do something like a soft launch. So we'll launch it. Only you and other government agencies can see this for the first 6 months. Get ready for the fact that the general public's going to ask you what's going on and who's working on it. So you've got a little time to ramp up and then kind of open the door. So those are the kinds of discussions we find ourselves in. And frankly, I think they're healthy. I mean, we're trying to approach this as a partnership. We're not trying to stick it to anybody. But there is a lot of information that is sort of hidden in the shadows. And as it comes out, it creates sometimes, I would like to think as very productive discussions, but some people might say very awkward discussions. We're also having some trouble figuring out how to do comparisons between communities. A lot of times we have great data. We could report it down at a highly granular level, but then we have confidentiality problems, so we have to average data over many years, and then that loses some of the currency. So there's all those kinds of trade-offs. And the last thing that I would say is a problem is, how do you get the community to embrace the system? Now, San Francisco launched their site, and traffic has been rising. It started very modestly, but it's been rising at a 50% increase per month for 5 months. That's very high rates of internet growth. So it's very exciting. I think just like we were looking at those second generation, 100 million people online looking at health-related information, 100 plus. Well, I think this kind of stuff will be consumed too, but people don't know it's there. They don't even know to ask for it. So it's going to take a little time for this to become kind of commonplace. And the last slide I have here is just a little bit of our vision, which is, at the end of the day, what we're trying to do is democratize information and promote really informed community change for any stakeholder that wants to get engaged, whether it's the official body responsible for that subject or whether it's some other group, an employer, a church, foundation that's getting involved. And we want this to be widespread here in the U.S. and internationally. Frankly, the team that put this together are primary heart and soul is to make this available internationally, especially in developing countries. But we're going to test it here and get all the kinks out, and then we're basically looking for different models, financially and otherwise, to how to make this available on a very widespread basis. I think the last thing that I want to say is that we have a very open philosophy here, and so I'd like to kind of reach out and make an invitation to researchers, policymakers, organizations that are involved in different interventions or collecting data to work with us, because we do not have a built here kind of mentality. There is way more to do than we can ever get to. But I think we've got a pretty good formula. Our 3 pilots are extremely happy. We'll be opening this up to a variety of other communities beginning in a few months. So we're on a good trajectory. But if there are experts in different areas within any of these taxonomy areas, you want to get involved in terms of moderating discussion groups, contributing content, reviewing best practices, nominating best practices, the list goes on and on and on, please get involved. We're very excited about where this is going, but it will require a lot of ongoing work. So let me stop here and let's open this up to some discussion.
I had 2 questions. The first was in terms of spreading the word. What do I type in if I want to Google this? Say I can't remember the website you just flashed up there, and I want to get to the local site for wherever I am in the United States.
The short answer to that, I'll give you a today answer and a near term. Today, you can type Health Matters, because that's what San Francisco calls theirs, Health Matters, like it counts, plus San Francisco, and it'll pop up in the first 2 or 3. You can Google that, for example. But we plan to have a much more consistent kind of marketing campaign, and we have some fundraising going on to actually promote some of what's called search engine optimization around this, but that hasn't taken place yet.
Okay, the second question would be, it seems that your rating system for the health indicators is a bell curve, right? So as the bell improves, hopefully as the impact goes along, the distribution will narrow up and everybody will get into the green, but of course someone has to be in the red in that case.
Yes.
Does it move to an absolute scale over time? Or?
Well, so would that we would have that problem. But you're absolutely right. And I think the short answer is in the foreseeable future, we don't see that bell curve moving too quickly. We do expect that the criteria will, I shouldn't say expect, we hope that the criteria for being in the green will ratchet up over time. And there may be a point in time where you move to more absolute measures, but we're pretty far from that, at least for the vast majority of these indicators today. Other questions?
Hi. You mentioned a vision to deploy the system in developing regions. What do you see are primary challenges and differences in those regions to this system? And I had a specific question within that, which is you mentioned this taxonomy of 4 different generations of IT in this area. Where does this rank, this 4th generation IT for developing regions?
Yes. Great question. So let me take the last one first, which is you don't have to go through the progression of the generations. So in a developing country, for example, you can just implement the 4th generation community health information system. Let's call that a top-down system, loosely speaking. And you can, in parallel or later, implement a 3rd generation personalized health information system, which actually may be more infrastructure intensive. So that's a whole discussion that we can pick up perhaps later. As far as what some of the constraints are in developing countries, you don't have as much data. So you can't report 153 indicators like you can for San Francisco. You might have 32. I'm arbitrarily picking a number. The second thing is the quality of the data you would have to question, and you'd want to report back about that so people don't misuse the information. But there can be immediate benefit on best practice sharing. That knows no borders. Anyone working on any health, environmental issue can learn from people around the world and from the contacts that can put them directly in touch with efficient interventions.
I might make a comment on developing countries first and then ask another very different kind of question. I've worked most of my life with developing countries. In terms of constraints, one of them I think you're going to run into very quickly is what you alluded to in terms of the sensitivity of one of your users about unfavorable data. the politics is so fragile in almost all developing countries that I have found in work I've done that even very low-level evaluations of educational progress, for example, they've actually terminated the project because they didn't want to hear what would happen. And of course, the other constraint is just having the bandwidth available for this kind of system. It's just not available in most places, but that is gradually changing. That's a big constraint. But my question was totally different. In terms of sustainability of this really wonderful resource, what are you looking for in terms of long-term funding? Who'll pay for it? What kinds of entities will on a regular basis? And secondly, how long does your grant last so you can continue to nurture it up to that point?
Yes. So we were hoping you had an answer on the funding question. No. We basically have there are many models that we're looking at. And I'm going to oversimplify. Here in the United States, the 3 pilots that we are working with are all paying us an annual licensing fee. And they frankly have all told us that it's too low. Our model shows that if we were to make it available at this licensing fee for other communities in the United States, not all the United States, just a few dozen more communities, that this can be entirely self-sustaining financially. So that's one piece to the model. Having said that, that doesn't address developing countries and a variety of other needs where I think the answer will be to go for sponsorship opportunities and not go community by community, but sort of do countrywide systems and work with grants from very large organizations that want to be associated with that kind of work. I know we're more or less out of time, but if there are any other questions, I'm happy to stay. Yes?
Well, one more question. From an IT perspective, if you had a wish list of sort of the toughest technical problems that you could solve, I imagine data integration would be high on that list. What would be sort of high on that list?
Well, it may not be the exact spirit of your question, but of course what I would really like is that everyone could have access to the internet so that they could actually get to this kind of information, especially again in developing countries. But sticking with, I think, the spirit of your question, our technical challenge, we have more of a human challenge of reviewing all of this content, rating it, etc. Technically, this system actually can handle a lot of users and replicate very rapidly. So the 1 or 2 areas are A, the data integration you mentioned. That's always a challenge when you're trying to integrate different databases. But the second is to try and automate as much of the updating process as possible. That's a tricky, if you've got hundreds of indicators and they're all updating, you want a self-automated process as much as possible, not people running around reminding themselves to go update materials.
So we're actually out of time, but I know if anyone else has any questions, Professor Van Brunt would be happy to stay for a few more minutes and help answer them.
Great.
Thank you again for a great talk. I will see you all in September. Thanks again.
You're welcome.